Iliopoulos and Dr. Panos Pipilis. Professor Iliopoulos is a very experienced surgeon, and I would like his input, and then I will have the input from Dr. Pipilis on from his cardiological perspective.
Thank you, Ari. Thanks a lot. Really, I am very impressed from two great speakers who gave us excellent lectures. And I want to stop my mobile because it announced. Excellent talks. I think really that, and I have comments for both speakers, and I have questions also. I think that the future of cardiac surgery in terms of valves or even coronaries would be the endoscopic. That's what I'm fully impressed. For aneurysm, which is my main interest, would be more difficult. Maybe from small incisions we can excise an aneurysm. So I'm in a safe area. But coming back from Houston, I remember that my colleague there, who is expert in robotic surgery, told me that in the United States, cardiac surgeons moved from thoracoscopical procedures to robotic procedures. And I was very impressed. If it's happened, this is really amazing. And what he told me to comment this slow motion to this era is that when you operate from using a robot, you are in the barrel, whereas where you operate with video assisting, your hands and instruments are out the barrel, which makes a great, of course, difference. The main problem I can see is the time that those operations really need to be done. And the second is that, unfortunately, for our era, there are not so many valves to operate because a huge number are done by cardiologists, interventional cardiologists. I can see that most surgical valves really went down to 30%, 40%. And now my main point is that in order to stop these interventional cardiology procedures for both valves, the only way we have to answer is this minimal approach. Really, I don't understand how we can stop this huge new era for valvular approaches via interventional cardiologists. So this is my main comment for young people to move to the robotic and endoscopic surgery. And of course, for me is another point very, very important. I would like to comment. In order to go into the thoracoscopic era or later on to the robotic, you must know very, very well the open procedures. If you don't have an enough number of procedures, you don't know how to operate the valve. And both Aris and myself, we started in an era where we had a lot of opens. So we could address ourselves in such conditions and to become an excellent valve operator, then moving from replacements to repairs, and now you can go and see and repair via the thoracoscopic. So another point that we have the difficulty in private sector is the cost. We have a huge cost here in Greece. 20 years ago, everything was for free. Now we have such big problem. But I would love to congratulate both of you because this effort is great and continue to help young cardiac surgeons to move to this direction. Thank you.
So
what is your input?
I'm thinking about which. There were a lot of questions. First, I think if you think about that, we need to. There is a battle between cardiac surgeons and cardiologists, and who will win the battle. I think we need to approach it differently because there is some sort of importance in honesty. If you look at the registries, big registries, you see that the repair rate of the mitral in the big registries is around 50%, which is very low. And we know the most common pathology of mitral valve prolapse, P2 prolapse, is between 60 to 80%. So 50% is like throwing a coin. I can say I can repair all the valves possible. I have a good results in Maastricht. But it doesn't give a solution to the problem in the field, which is you have a disease that you need to get it repaired, and in general, it doesn't get that. So there is a reason that the cardiologists are doing more transcatheter approaches, one of the reasons. I think the solution is differently, and on what we have established at Maastricht. At the end, you can also say it is all about money, it is all about power. But even if you consider it is all about money, if your program runs well, you provide a good care, you get more patients. You know, in cardiac surgery and cardiology, that's your referral reflects the quality of care that you provide. So that's why I think if you team up with the cardiologists, and when I started the program in mitral, there was no mitral program. There was only 15 cases per year, and the cardiology had no program. I established the program, grew, and at some point, cardiologists, MitraClip, we stimulated to do the MitraClip. We thought, okay, if you have a good MitraClip program, you get more referrals, but you cannot do MitraClip in all patients. But if you select together a good patient for MitraClip, a good patient for surgery, the quality goes up, both groups get more patients and more interventions. So that is, I think, this should be the established philosophy for future. I know in Greece, a different structure is very difficult, but I think that is the future. Future is that you team up with a group of physicians based on same pathology and treat patients, provide a good quality of care based on the guidelines. And this is an ideal. Is that possible? Why is it possible in Maastricht? Because the group have the same department, same management, same money structure.
Yeah. Said, I totally agree. My point is that we have to teach ourselves to move to this direction. This is very, very important.
Yeah, so that is the other point is you have to do that anyway. That's why
Oh,
I
yeah,
have been
absolutely.
doing this for a decade.
Absolutely.
There are two things: teach, standardize. Teach and standardize.
This
And
is very,
these
very
two things
important.
are
I
important.
totally agree. Thank you.
Okay, and it's my turn to thank Dr. Panos for inviting us. Congratulations for the seminar. It's very interesting. We enjoyed both talks, and Dr. Iliopoulos, who is a cardiac surgeon, said he was impressed. So imagine how much impressed I am, which I'm just a poor clinical cardiologist. And Dr. Panos was clever enough not to call an invasive cardiologist here to comment on the extreme achievements of cardiology in repairing many of the valves. Anyway, I will stay only in the comparisons between techniques. As you said, I enjoyed what you said, that in 6 months what we need to see is a competent valve. And this, we don't care how you did it, as long as you did it well and it lasts. So even the classical way does that excellently. And so any new technique is compared and tries to find some advantages in terms of secondary endpoints, pain, blood loss, and so on. So if we do, you mentioned a lot of trials, which meta-analysis. Are these are randomized trials or just series and propensity matching scoring? So that's one question. Because if you are to compare, non-inferiority is very easy to prove with any technique, and so you rely on the secondary endpoints. And so if you had to compare a new technique like robotic in terms of video assisted, what secondary endpoints would you choose to make to prove that something is better and worthwhile going on with that?
Thank you for your comments. I think with regard to your first question, the data is mostly based on retrospective studies, meta-analysis, registries, and there is one big randomized control trial, UK mini trial, but that was expert-based, which is very, very interesting. So you were randomized to stenotomy or minimal invasive, done by an expert mitral valve surgeon. And they found no difference in, obviously, mortality and repair rate and so on. And they had a secondary that they looked at the recovery time, but the recovery time was I think 3 months, 6 or 3 months, and there was no difference. But the issue is, for stenotomy, the sweet spot is that you need 6 weeks to recover from your sternum. So in that trial, there was a difference before that, but not if you look beyond that. What I showed you from Dutch registry, that is a real-world data, but a data which is prospective, validated, and audited. And there is no difference in a sense of mortality, safety issues, and so on. Secondary endpoint, yeah, there is a big difference in AF, for example. Postoperative AF is
less.
Is much less. And what we see in the clinical practice, but there is not a good randomized study showing that. Obviously, if you don't have your sternum open with a small incision, your recovery time is much better. But what is, I think, very important is, if you have tomorrow a patient and you have to send that patient for mitral repair, and you have 2 choices: an expert stenotomy mitral valve surgeon and an experienced minimal invasive surgeon, should send it to the stenotomy expert surgeon. It is what I want try to say is the quality is determined by expertise at the level of mitral. And one of the very evident studies was based on the STS database. In STS database, if you look at the repair rate, in general, is very low, 50%. And then they look at the minimal invasive surgeons. And in US, about 10 to 20% is done minimal invasively, robotic of. And the repair rate was much higher among the minimal invasive surgeons. But why was that? Because those surgeons did more operations and they were mitral valve surgeons. So that is the issue. It is not the quality issue is not per se the procedure. Why should you do a better job endoscopically with chopsticks at the mitral level? You should do the same quality of job. All the issue is a secondary endpoint, as you mentioned.
And perhaps one question for Professor Jegaden. I was impressed with the removement of calcium from a heavily calcified mitral annulus calcification. Is there a problem there that you don't have the tactile, the sensing when you're doing that with the assistance?
Not really, because it's amazing how the human are able to adapt. In fact, you don't have the feedback of the sensation of the feeling. Okay, you developed a specific kind of that capability only by the visions. So according to the visions, you are able to evaluate what is the pressure on the tissue and so on. But now in the new system, there is a feedback. It's not perfect, but they give the feedback of the feeling and so on.
Still, it's an impressive operation, because removing all this calcium, the annulus you had, you have a high risk of dehiscence, atrial ventricular dehiscence.
Yes, but there is some
so
there is only the fat remaining.
This is the great fear for us.
Yeah, exactly. Only when, but it's for the reason that I like. It's not mine. I explain, but I like to show this video, because when you see such cases, you understand the interest of the robot. Yeah. There is no questions.
Totally.
And to complete the answer to your question, for me, the discussion between stenotomy or mini-invasive, it's completely has been. There is no questions. It's the past. Okay. And also, maybe if we move on the direction of the mini-invasive 10 years ago, okay, we would be now in better situations to compete with the interventional cardiologists and the new technology. Because all this interventional cardiology, it's a palliative. We know that they will never give the same result as surgery. Yeah. And particularly by the time. Okay, according to the long-term follow-up of the patients. But if we are still offering to the patient the stenotomy, we lose the market, and we have already lose the market in many situations.
I have another question for you, Professor Jegaden. I will continue the question of Professor Iliopoulos. And what do you think? You were 2 decades academic surgeon, so you have trained many surgeons, including me. What do you think for the next generation? Should they pass through a standard classic surgery first, or they can go directly to the, for example, minimally invasive mitral repair?
No, they can. I think that it can do directly to the mini access, because first it's the standard, the gold standard now, so go directly on this way, and it's not because you can do that. I think that it's just a question. You have to think that it's only a question. How to. If you imagine that you have to enter in the room, it's just a question how you enter. You enter by the window, by the door, by the roof. You can break completely the wall. It's just a question of that. The access of the lesions. After that, if you are able to do something with the mini access, you are able to do that in the stenotomy, because it's just a problem of the action. When you reach the lesions, you do exactly the same. There is no specific dedicated procedure for something, depending on the access. So for me, you can start with the mini, and maybe it will be easier to go for stenotomy after that.
Thank you.
Okay.
Thank you. Any other questions?
can move forward